So first of all, I'd like to thank the organizers for giving me the opportunity to talk to you about what we've been doing for the last few years on a topic that aims at evaluating the impact of anti-TNF in melanoma immunotherapy. And I would like to share with you concepts from basic findings to the clinic. Cutaneous melanoma is a bad prognosis skin cancer, which is characterized by key driver mutations such as BRAF mutations and NRAS mutations, leading to the constitutive activation of the MAP kinase pathway. It is the 19th most common cancer in the world. Melanoma immunotherapy has changed the prognosis of patients affected with advanced melanoma, especially the one that is based on the use of anti-PD-1 and anti-CTLA-4 antibodies. However, more than 40% of patients do not respond to immunotherapies, and 10% of good responders relapse within 2 years post-induction. There are no specific predictive biomarkers of resistance, and most of the patients develop immune-related adverse events such as colitis that can be efficiently treated with anti-TNF antibodies. Because TNF plays a dual role in cancer, including in melanoma, it is very important to evaluate what could be the impact of anti-TNF in the context of melanoma immunotherapy. Indeed, TNF, which stands for tumor necrosis factor, has been first identified as a cytokine able to trigger tumor necrosis by acting directly on cancer cells, leading to cancer cell death by apoptosis or necroptosis, or by triggering endothelial cell death. And recombinant TNF can be administered in isolated lymphoperfusion protocols in the clinic, and these lead to potent tumor regression. So in that sense, TNF can be considered as a good cytokine able to trigger tumor regression and a good cytokine to fight against cancer in general. However, a growing body of evidence indicates that it can behave on tumor and cancer by acting as a tumor-promoting factor, facilitating cancer cell proliferation, migration, differentiation or dedifferentiation according to the context, and also leading to resistance to therapies. And also in the tumor microenvironment, TNF has been shown to facilitate the tumor angiogenesis, stromagenesis, and modulating the leukocyte infiltration and activity. And with the last papers in hand, one can consider that TNF can facilitate tumor progression and metastasis and can be considered thus as a bad cytokine. So this is in this general context that we are trying to address this following question. What is the role of TNF-alpha in experimental mouse melanoma model? So to answer this question, we intradermally injected melanoma cell lines in wild-type mice, and we evaluated the impact of TNF blockade on melanoma growth, anti-melanoma immune response, and anti-PD-1 therapy. The first set of experiments I'd like to share with you are based on the administration of the graft of B16K1 mouse melanoma cells. Those cells are basically B16F10 melanoma cells that are stably transfected with a plasmid encoding MHC1. So we grafted those cells in wild-type mice, and despite the overexpression of MHC1, this cell line is able to grow and to form tumors in immunocompetent mice. And we evaluated the impact of etanercept injection in those mice. And etanercept is a soluble form of the TNF receptor 2 that is used in the clinic to treat patients affected with autoimmune diseases such as rheumatoid arthritis. And we've been using etanercept because it can cross-react with mouse TNF. And as you can see with the red curve, etanercept potently reduces the tumor growth of these B16K1 melanoma cells. This is associated with an increase of the infiltration of tumors by CD8 positive tumor infiltrating lymphocytes as evaluated by flow cytometry or by immunofluorescence. So all the blue dots corresponds to CD8 positive TILs. So indicating that etanercept reduces the melanoma growth in wild-type mice, most likely through its ability to enhance the content of tumors by CD8 positive T cells. And accordingly to this tenet, so we performed the same kind of experiments in CD8 knockout mice, and we observed no effect of etanercept in CD8 knockout mice, indicating that etanercept can limit the tumor growth only if cells express CD8 alpha molecule, further indicating that etanercept can facilitate somehow the CD8 T cell dependent immune response and thus limit the melanoma tumor growth. Because the administration of anti-TNF alone was not enough to trigger total tumor regression, so we thought that it would be worthwhile evaluating the impact of anti-TNF together with the co-administration of anti-PD-1 antibodies that are used in the clinic. And to do so, we grafted wild-type mice with B16K1 melanoma cells, and we monitored the tumor growth in control mice untreated and in mice treated with anti-TNF alone. And as you can see, there is a slight reduction of the tumor growth with anti-TNF alone. And the same trend can be also observed at a higher extent with the administration of anti-PD-1 alone. And anti-PD-1 alone can trigger the tumor regression of 7 tumors out of 24. And the most striking results, most important results, was the fact that the co-administration of anti-TNF together with anti-PD-1 leads to the tumor regression of 18 tumors out of 24. So this indicates that both molecules, anti-TNF and anti-PD-1, somehow exert a kind of synergistic effect. So this was also evidenced when we looked at the overall survival of the mice. So the combination of anti-TNF together with anti-PD-1 is much better than the administration of anti-PD-1 alone. And also we made an interesting observation is the fact that when the mice were able to totally reject the tumors, so we re-challenged them 2 months after the first melanoma cell graft, and we observed no tumor progression at all, indicating that somehow the combination of anti-TNF and anti-PD-1 do not impair the establishment of memory T-cell dependent immune response, and the mice who were able to totally reject the tumors were totally vaccinated against B16K1 melanoma cells. Mechanistically, we evaluated the impact of anti-TNF alone, anti-PD-1 alone, or the combination of both. And we evaluated by flow cytometry the content of CD8 positive T's, and we observed that anti-TNF potently accumulate the tumors with CD8 positive tumor infiltrating lymphocytes. And this is not further increased with the administration of anti-PD-1. So next we evaluated the impact of anti-TNF on the expression of secondary immune checkpoints that can be triggered by anti-PD-1 antibodies and that have been described as being involved in acquired resistance to this kind of immunotherapy. And among all the different secondary immune checkpoints we evaluated, we found out that the TIM3 is upregulated on CD8 positive T's in a TNF dependent manner. So as you can see, anti-TNF totally prevent the upregulation of TIM3 on CD8 positive T's upon anti-PD-1 injection. And we confirmed the putative link between TNF and TIM3 by evaluating correlations of expression of both genes in the TCGA melanoma cohort and also in patients treated with anti-PD-1 therapy. So next, it was important to evaluate whether recombinant TNF-alpha can facilitate the expression of TIM3 on activated CD8 T cells in vitro. And indeed, this is the case. This is what we observed in mouse CD8 T cells that were activated and incubated with recombinant TNF. So this is the blue curve. And when we did the same experiments by using a TNF receptor 1 deficient CD8 T cells, so we observed almost no increase of TIM3 expression upon a recombinant TNF. So this indicates that TNF can potently induce TIM3 expression on activated CD8 T cells in vitro, and this occurs in a TNF receptor 1 dependent manner. And also we are able to show that by incubating human CD8 positive T's with TNF, we observed an upregulation of TIM3 expression, and this is further enhanced by co-culturing T cells with autologous melanoma cell lines. So next we evaluated whether anti-TIM3 can also reduce the tumor growth together with anti-PD-1 to demonstrate that TIM3 was indeed involved in the resistance to anti-PD-1 under our experimental conditions. To do so, we administered mice with anti-PD-1 alone, or in combination with anti-TNF, or in combination of anti-TIM3, or we also performed the triple combinations, anti-PD-1, anti-TNF, and anti-TIM3. And as you can see, under those experimental conditions for which anti-PD-1 was not able to reduce B16K1 tumor growth, the co-administration of anti-PD-1 and anti-TNF was associated with a significant reduction of tumor growth, and this is the same when we combine anti-PD-1 with anti-TIM3. So indicating that somehow the TIM3 expression on T cells is likely associated with resistance to anti-PD-1 therapy under our experimental conditions. And when we performed the triple combinations, anti-PD-1, anti-TNF, and anti-TIM3, we did not observe a further reduction of tumor growth, indicating somehow that TNF and TIM3 expression are on the same signaling pathways to trigger resistance to anti-PD-1 therapy. So next, we documented the fact that under our experimental conditions, TNF triggers the activation-induced cell death of CD8 positive Ts upon anti-PD-1 therapy. This was the case in wild-type mice treated with anti-PD-1 antibodies. So we observed the fact that TIM3 positive and PD-1 positive CD8 positive Ts indeed died upon anti-PD-1 therapy. And this phenomenon is totally abolished in TNF deficient mice, indicating that somehow anti-PD-1 facilitates the production of TNF, and TNF is able to trigger the activation-induced cell death of CD8 positive Ts that co-express TIM3 and PD-1. So this is another way to represent the phenomenon of activation-induced cell death. So on the left, you can see that the CD8 positive Ts that co-express TIM3 and PD-1 in wild-type mice died upon anti-PD-1 therapy, and this is totally abolished in TNF deficient mice. To conclude from the basic findings we obtained at the Cancer Research Center of Toulouse, so we provided evidence that the production of TNF in the tumor microenvironment is associated with the TNF receptor 1 dependent signaling pathways, limiting the accumulation of CD8 positive Ts in the tumors and facilitating an immune escape phenomenon. Upon anti-PD-1 therapy, we observed the production of TNF in the tumor microenvironment, and this leads to the activation-induced cell death of CD8 positive Ts that co-express TIM3 and PD-1. And we do think that this is associated with partial responses in most of the mice. Upon anti-TNF administration, we observed a huge accumulation of CD8 positive T cells into the tumors. But this leads to partial responses only because most of the CD8 positive Ts express PD-1 that inhibits the activation of the lymphocytes, limiting their activity into the tumor. So this is why when we co-administered anti-PD-1 together with anti-TNF, we observed frequent tumor rejections because anti-PD-1 did not trigger activation-induced cell death process anymore and did not trigger TIM3 expression at the cell surface of CD8 positive Ts because both phenomena are TNF dependent. Okay, so now I'd like to move on the clinical trial in advanced melanoma patients we carried out at the IUCT, which is the hospital part of the Toulouse Oncopole. So this clinical trial is a phase 1b clinical trial called TICIMEL, and it is carried out in 30 advanced melanoma patients. Basically, this trial is carried out under the supervision of Professor Nicolas Meyer, who is the oncodermatologist here at the hospital part of Toulouse, and I'm in charge of the exploratory part of this trial. So this trial is based on an induction phase based on the concomitant administration of ipilimumab, an anti-CTLA-4 antibody, nivolumab, an anti-PD-1 antibody, and one anti-TNF molecules. And this is followed by a maintenance phase based on the co-administration of nivolumab and anti-TNF molecule. And this is carried out in 30 advanced melanoma patients. And this trial is funded by the Bristol Myers Squibb laboratories and performed at the hospital part of Toulouse Oncopole. In this trial, we have two cohorts of patients. The first cohort is treated with ipilimumab, nivolumab, and certolizumab. Certolizumab is a humanized fragment antigen binding prime. It's not a proper antibody, but it's an anti-TNF molecule. And the other cohort of patients is administered with ipilimumab, nivolumab, and infliximab, which is a chimeric monoclonal antibody. For the exploratory part of this trial, we are analyzing blood and tumor samples collected before treatment induction and along therapy. The primary objective of this clinical trial is to evaluate the dose-limiting toxicities, the DLT. So here are the criteria for the DLT, and we consider that if no more than one patient among 6 presents a DLT during the first 12 weeks, the combination is considered as safe. So we are delighted to observe no DLT in the certolizumab cohort and only one DLT in the infliximab cohort. So we can consider that both combinations are safe in humans. In this trial, we evaluated the tolerability by monitoring the adverse events in both cohorts. We observed an adverse event profile that was comparable to the one observed with ipilimumab-nivolumab combination, and all the adverse events were clinically manageable by interrupting treatment and by administering corticotherapy. And also we observed that infliximab is better tolerated than certolizumab. We next evaluated the efficacy of both treatments, and in the certolizumab cohort we observed most of the patients responded and some of them displayed a complete responses. In the infliximab cohort we observed that 50% of the patients responded. As you can observe on the CT scan images, so we observed complete tumor regression in both cohorts from the certolizumab and infliximab cohorts, even in patients with a big liver metastasis, which is very difficult to treat. So in the certolizumab cohort, we observed 4 complete responses out of 8 patients and 3 partial responses. And in the infliximab cohort, we observed only 1 complete response and 2 partial responses. From the first part of the TICIMEL clinical trial, we observed a high objective clinical response rate in the certolizumab cohort. So what are the conclusions, hypotheses, and perspectives from the first part of the TICIMEL clinical trial? The only conclusion we can draw is the fact that both 3 therapies are safe, and we can carry out this clinical trial with an expansion cohort of 18 more patients. We can hypothesize that the 3 therapies better tolerated in the infliximab cohort. Anti-TNF, certolizumab, and infliximab do not impair the anti-tumor immune and clinical responses in the context of the ipilimumab and nivolumab combination. Certolizumab seems to improve the response rate with 4 complete responses out of 7 patients that were clinically evaluable. And we observed numerous signals of synergistic clinical activity between certolizumab and ipilimumab and nivolumab, including immune-related adverse events and also objective response rate. So this is why we decided to enroll 12 and 6 more patients in the certolizumab and infliximab cohorts respectively for the expansion cohort. We are monitoring the pharmacodynamic impact of anti-TNF, infliximab or certolizumab in ipilimumab and nivolumab treated advanced melanoma patients at the Cancer Research Center of Toulouse. And this is a big project that is funded by the Fondation ARC and Fondation Toulouse Cancer Santé. Together with two PhD students, Mathieu Virazel, who is a second-year PhD student, I co-supervised with Dr. Céline Colacio, and Mathieu Genet, who is a first-year PhD student, I co-supervised with Dr. Vera Pancaldi. And both students are part of the CARE Graduate School. And also, we are evaluating the role of the ceramide metabolism in TNF-induced melanoma dedifferentiation in the context of the thesis of Karine Dufaux, who is a third-year PhD student. I co-supervised with Dr. Nathalie Andrieux. I'd like to acknowledge people from my lab, so all my lab members and also all my collaborators on this project. I'd like to give a special acknowledgement to Dr. Anne Montfort, who successfully passed her exam to become a full-time researcher at INSERM. So thank you very much, Anne, for all you did on this project. I'd like to thank the technological platform at the Cancer Research Center of Toulouse and also the animal facilities. And also I'd like to thank all the fundings for this project. And thank you very much for your attention.